With that, I would invite the next speaker, Dr. Samar Hafida, to talk on a topic, bariatric surgery for obesity management in diabetes. Is the tide going up or down? We have Dr. Samar Hafida, who is instructor in medicine, Harvard Medical School, and endocrinologist and weight management specialist, director, medical education, global education and care division. She established the diabetes metabolic surgery clinic that specializes in the study and management of patients with diabetes who undergo weight loss surgery, specializes in management of patients with obesity and complex metabolic disorders, and she advocates to end obesity-related stigma and end disparities in healthcare. She's director of professional medical education. With those high credentials, Dr. Samar Hafida, we look forward to your talk.
Thank you very much. I'm going to try to share my screen now. And here I go. And let me know, does it show? Can you see my screen and can you see my slides? Is that a yes?
Yes, we can see your slide and we can hear you properly.
All right, well, thank you, everyone. Good evening and good morning from Boston. Thank you for the very kind introduction. I'll go ahead and start. My topic today is a little bit different than what was proposed earlier. I'm going to be talking about metabolic surgery as an intervention for obesity and its metabolic consequences. I have no disclosures other than I am not a surgeon. I'm an endocrinologist. However, many of my patients do receive metabolic surgery as an intervention for their disease. So I think it's incumbent upon me and everyone who has patients that have weight loss surgery to understand what the evidence is. I'll just go very quickly, and you know these figures that obesity is a global phenomenon. 1 in 4 individuals are living with obesity, and the prevalence has really gone up since 1975. It's tripled. And you can see this parallel rise in prevalence in type 2 diabetes as well, where in 2019, there were about 463 million people around the globe living with type 2 diabetes, and it's projected to increase to 700 million individuals. So we really need powerful evidence-based interventions to treat this global pandemic or epidemic. I just want to begin my talk by summarizing the previous talks and defining obesity. So obesity is a chronic disease, as you all know, and it's characterized by increased energy intake to defend a dysregulated set point. That's really what obesity is. And there will be periods of remissions and relapses that will result in a pathological accumulation of adipose tissue, resulting in morbidity and mortality. So how do we alter the morbidity and mortality that results from increased accumulation of adipose tissue? As you know, obesity is linked to over 200 diseases, ranging from, of course, type 2 diabetes to everything else, mechanical and emotional and respiratory and everything else, including cancer. So when we talk about management of obesity, what we're really doing is talking about the management of comorbidities. So there are 2 aspects to any intervention of a chronic disease. Can we prevent it from happening? And can we prevent or can we treat its complications? So that is also true for metabolic surgery. Today, I'll be talking a little bit about prevention of type 2 diabetes using metabolic surgery, but mostly focusing on how surgery impacts type 2 diabetes and cardiovascular outcomes, which are the 2 top comorbidities that lead to loss of life in people with diabetes and obesity. So let's start with the case. This is Siddharth. He's probably a case that all of us have seen before. He's 33-year-old and he lives with class 2 obesity, and he has a past medical history of type 2 diabetes for a while. You also discover that he has metabolic liver disease, and on further history, he tells you that his family history is significant for cardiovascular disease. So let's stop and pause here and think, is metabolic surgery a good intervention for Siddharth? So first of all, what is metabolic surgery? There are different flavors of weight loss surgery that are performed. Some of the more common ones that you're familiar with are Roux-en-Y gastric bypass, which is shown in the center panel there, as well as sleeve gastrectomy and adjustable gastric band that's not performed as often, at least here in the United States. Other newer forms of gut alteration or weight loss surgery include SADS and OAGB, or one anastomose gastric bypass, and some of the more involved or extreme metabolic surgery procedures are BPD with duodenal switch. So we'll be talking mainly about the studies that involve the right side for procedures and not so much the SADI or the OAGB. All right, so we're going to be talking about the impact of metabolic surgery first on type 2 diabetes and then later on cardiovascular outcomes. So there are many observational trials and prospective clinical trials looking at thousands and thousands of patients with obesity and type 2 diabetes. But what I'm going to focus on today is what is the evidence from the randomized open label control trials. There has been in the past a lot of criticism amongst the medical community in reporting of the beneficial outcomes from bariatric surgery because the studies are observational only. So as of today, there are 12 randomized control trials with a total, including a total of 894 participants with obesity and type 2 diabetes. And looking at whether intervention with lifestyle versus surgery has any impact at all on glycemic control. So in all of these randomized controlled trials, the onset, everyone had type 2 diabetes, but they were different in when they developed type 2 diabetes. And as you heard from Dr. Halberg a minute ago, type 2 diabetes is a very different disease depending on the chronicity of it. People who have pre-diabetes are very different than individuals who've had diabetes for more than 10 or 20 years. So the onset of diabetes in this cohort of participants was very different, ranging from just diagnosed to over 8 years. About half of these participants were using insulin at the time of enrollment, and their body mass indexes differed from 25 kilogram per meter square to up to 53. So you can see there's a wide difference and wide range of individuals who are included in these 12 randomized controlled trials. So what did they do? What did these investigators do? They randomized the participants included in their trials to either a bariatric surgery, whether it was Roux-en-Y gastric bypass or sleeve or an adjustable gastric band, or a BPD with duodenal switch. But the control arms were quite interesting. The intervention with lifestyle management were very different. They ranged from recommending the ADA nutrition guidelines, like you heard a little bit earlier, with various percentages of carbohydrate intake, protein, and fat, macronutrient composition in the diet, to lifestyle interventions that mirrored the lookahead trial. Some studies use pharmacotherapy as well, or some form of hybrid. But all of the participants received not only nutrition recommendations, but physical activity recommendations and counseling and coaching. Here, the primary outcome in all of these 12 RCTs was diabetes remission. The diabetes remission criteria differed in each individual study, and they really ranged, and they were very different. Some included an A1C of less than 6%, some were 6.2% or 6.5%, and some even included having an A1C criterion with or without medications. There was one study of the 12 that had fasting blood glucose of less than 7 millimoles as their primary outcome. So you can see they're very heterogeneous in what they decided diabetes remission was. And I still think that this is a very important topic for debate. I know there was a recent paper from the European group who did decide what diabetes remission was, but I still think it's a very important thing to discuss and really hash out. The duration of the studies were also different. So the reporting of the conclusions differed from either 6 months up to 5 years. And we have one study that reported outcomes of even 10 years. So let's take a look at what happened. This is a very busy table, but I'll try to summarize it the best I can. On the very left column is the primary investigator, the author of the study, with these p-value, so whether or not it was statistically significant in terms of outcomes or not, and the duration of the study. So you can see, like I said earlier, the duration of the study differed very much from either having up to six months or up to 60 months or 5 years. In the middle columns are the percentage of individuals who actually achieved the primary outcome, which was remission. And on the very right-hand column was the outcomes for diabetes remission in the non-surgical group, or the intervention, lifestyle intervention group. So you can see that the number or the percentage of individuals who had bariatric surgery or metabolic surgery who were able to achieve the primary outcome was significantly higher in all of the interventions, except for one at the very bottom here in the blue box, comparing adjustable gastric banding to lifestyle intervention, where there was no difference among remission rates with using a lap band versus just medical intervention alone. In the red box that's highlighted are these two studies that had the longest duration of outcome, which is about 5 years. So the STAMPEDE trial and Dr. Mangroni's group looked at Roux-en-Y sleeve gastrectomy, and Mangroni's group looked at the BPD with duodenal switch. And so you can see the longest outcomes right there. In the orange in the orange cells here are the studies that included people who've had a BMI less than 35. So most, at least in the United States, people who are eligible to receive bariatric surgery as an intervention must have a body mass index of at least 35 with one comorbidity, or more than 40 if they have no additional comorbidities. But what these studies showed in the orange boxes was that even individuals who had type 2 diabetes and they had lower body mass indexes still were able to achieve a significantly better outcomes in terms of diabetes remission over medical weight loss, even if their BMIs were lower. So we know that diabetes remission is a very fluid term, but what happened to some more impactful, measurable outcomes? For example, the percentage of subjects not using any medication after a metabolic surgery. This is often a question that your patients will ask you. If I do have surgery, does that mean I can come off of some of my medications, or do I still need to take them if I have this surgical intervention? So this slide is looking at the longest outcomes with it, which is the 5-year outcomes from the STAMPEDE trial in Dr. Mangroni's group. And at baseline on the very left there, you can see that the percentage of people who were not taking any medicines for treatment of diabetes was about 2% at the start, at baseline there. However, after 5 years of intervention, those people who were randomized to either Roux-en-Y or sleeve gastrectomy or BPD, after 5 years, had a significant proportion of them were not using any medications at all for treatment of diabetes compared to the medical group. And after 10 years, this was reported again from Dr. Mangroni's group. After 10 years of intervention, still 25% of those who underwent Roux-en-Y gastric bypass were still able to maintain a normal A1C with, and only 25% of them and 25% of them did not need any medicines at all. And in the BPD group, 60% still were able to, keep their A1C within normal ranges without any medications at all, versus 0. Nobody in the medical intervention group at all, after 5 years or after 10 years, nobody did not need any medicine. So everybody who were randomized to the medical arm, everyone needed medicines to treat their diabetes. So some medicines we use also for weight maintenance. So what about insulin? Insulin is what we what we use when we cannot achieve A1Cs that when our patients are not at goal. So what happened to insulin usage over time? This shows, again, the two studies that reported outcomes after 5 years and after 10 years. And as I said before, at baseline, about half of the individuals were taking insulin before they were randomized to either surgery or medical intervention, medical weight loss intervention. What this slide shows is that after Roux-en-Y or sleeve gastrectomy or the BPD, the insulin usage was significantly, the people who did not need any insulin, significantly more than the people who were just treated with lifestyle intervention. And after 10 years, only 5% of people who had a Roux-en-Y gastric bypass needed insulin to treat their diabetes. 0% of people who had the BPD needed insulin, and 20% needed insulin in the medical weight loss arm, which is pretty much what we see in clinical practice as well. So who is then the appropriate candidate? Is everyone an appropriate candidate for metabolic surgery? This was a retrospective or prospective observational study looking at a true diabetes remission, what I call true diabetes remission, and looking at remission defined as either fasting glucose less than 100 or an A1C less than 5.7% without any medication. So this was very, very strict in what the authors considered to be a true restoration of carbohydrate metabolism back down to normal. So what they looked at was 85 people with obesity and type 2 diabetes, following them every 6 months, taking their fasting blood glucose, taking their A1C, and following them for about 10 years. And what they found was 23% of people actually did achieve complete remission, 23% of the 85 people. So then they looked at, okay, who was more likely to actually achieve this strict, these strict criteria for diabetes remission? And they found that the predictors of remission was not surprisingly a short duration of type 2 diabetes, those individuals who've had diabetes less than 5 years, absence of insulin prior to surgery. And what was interesting was that after 10 years, the BMI among the people who achieved remission and did not, the BMIs were comparable. There was no difference in their body weight or their body mass indexes. So it seems that metabolic surgery has a beneficial impact on diabetes remission, independent, despite despite weight loss. So there's something more going on, hence the term metabolic surgery. So like I said before, I'm going to describe this intervention, metabolic surgery and diabetes remission. So this was a long-term observational study. This is not randomized control. This was from the Swedish obesity study, and it looked at, the development. What was the odds of developing type 2 diabetes in people who are at high risk if they received weight loss surgery versus if they did not? So you can see in the blue line there, over time, over a follow-up of 15 years, the control group, just diet and exercise alone, many of them developed type 2 diabetes over time versus the surgery arm in the orange. And at 10 years of follow-up, metabolic surgery was found to decrease the risk of developing diabetes by 88% after 10 years of having surgery. Compare this to the pooled results from all of those diabetes prevention trials, like the DPP and the Ching trials, and many of the diabetes prevention trials that we have. The pooled results from those interventions showed that with lifestyle intervention, you can decrease the risk of having diabetes only by 36% with lifestyle intervention, again, diet and exercise. So 88% if you've had surgery versus 36% if you've had lifestyle intervention. And for this reason, the ADA looked at the evidence and now endorses, and has been for several years now, that metabolic surgery should be included in the armamentarium of treating and preventing type 2 diabetes. So right now, as the standards of care tells us that anybody who has a body mass index of more than 40, if they have a class 3 obesity, or 27 or 37 if they're of Asian descent, they should be, metabolic surgery should be recommended for management of type 2 diabetes. People who have class 2 obesity, if they're not able to reach their glycemic goals with lifestyle intervention, diet and exercise, then also this group should be considered to have metabolic surgery as an intervention for type 2 diabetes. And it even goes on to recommend this type of intervention for people who have class 1 obesity as well. So we know that diabetes and obesity are, chronic diseases, and there will be times of remissions, and that's good. That's what we strive for, but also relapse. So eventually, over time, type 2 diabetes did return, or did erode. The remission rates did erode over time. So whether or not, so these were the outcomes over the 5 years and 10 years. So whether or not they've had individuals had Roux-en-Y or BPD or sleeve gastrectomy, there was over time some erosion, some decrease in the remission rates over time. And again, this is not to be unexpected. We do expect that, but the erosion rates were far less or far fewer than individuals who just received medical therapy. And those were the results from the randomized controlled trials. These are some results from prospective observational trials. So you can see that looking at 2 years, 6 years, 12 years, and up to 15 years, over time, the odds ratio for remission goes down. So at about 15 years, was 6.3% versus very higher when individuals first have surgery. So what Siddhartha wants to know is, can metabolic surgery reduce his cardiovascular risk? He really is worried about his family history having cardiovascular disease, and he wants to know if he's going to be recommended to have this intervention, does it improve his cardiovascular outcome as well? So this was a recently published study from Aminian's group in the Cleveland Clinic that looked at again, retrospectively, people who've had metabolic surgery, about 2,200 of them, with matched controls. And what they looked at, what was the cumulative incidence of cardiovascular outcomes after 8 years? So if people had metabolic surgery, whatever it was, what was their cumulative incidence of having a heart attack or stroke or dying from cardiovascular disease? So those MACE indicators. So it was about 30% in the surgical group versus 47% in the non-surgical group. And this difference was statistically significant. Not only did the major cardiovascular outcomes go down, but also all-cause mortality, heart failure, things like coronary artery disease, cerebrovascular disease, and even atrial fibrillation. So all of the cardiovascular markers that we look at in people who've had bariatric surgery over time, at least after 8 years, the cumulative incidence was lower versus the non-surgical group. And what about in those high risk people who've actually had a myocardial infarction? So we know that it's good maybe for cardiovascular prevention, but what if for secondary prevention of cardiovascular disease? In this again, observational cohort study, they looked at people who've had a bariatric surgery. There are about 1,018 of these individuals with 45 with matched controls. And a significant percentage of these people also had type 2 diabetes. And they also looked at these cardiovascular outcomes or MACE indicators. So what they found in this group, even for secondary prevention, even in people who've already had a myocardial infarction, in the red line, you can see the survival rates after metabolic surgery. And on the right-hand panel, you can look at freedom from myocardial infarction over time. So the percent of people who do not have either a recurrence of a myocardial infarction or who live longer is significantly higher in the metabolic surgery group versus the non-surgical controls, even with the best diabetes and cardiovascular secondary prevention interventions that we have. So one question that is asked a lot is from our patients and from amongst us, how much weight do you actually need to lose to gain some cardiovascular benefits here? So this study did try to look at just that. And after a median follow-up of about 5 years, the weighted risk, cumulative risk or benefit needed to gain cardiovascular benefits was about 10% after surgery and 20% of matched control. So if you wanted to gain cardiovascular benefit over time, over a period of 5 years, without surgery, you probably need to lose about 20% of your total body weight and maintain it. And for all-cause mortality, it was about only losing 5% in the surgery group versus 10% in the matched controls. So again, this looks like what we saw for the diabetes group. The amount of weight loss is not really the significant point here. The metabolic surgery appears to have other metabolic benefits independent of what the weight is. Let's compare this to the lookahead trial that we're all familiar with. And this was a very, very well done intensive lifestyle management study spanning over 9 years, and which did not show cardiovascular or mortality benefit. So another randomized control trial looking at some cardiovascular risk factors. In this case, it was hypertension, randomizing about 100 patients. And what the authors looked at here was, can we improve the number of medications that people take? Can people actually not take any of the antihypertensive over a period of 3 years, or they reduce the number that they're taking by at least 30%. And this again was in favor of bariatric surgery, where 73% of people who had Roux-en-Y gastric bypass achieved the primary outcome, which was just normal blood pressure without any medications, versus only 11% of the medical group. This is looking at life expectancy after bariatric surgery, and over time, and what happens again was from the Swedish obesity subjects group, and so mortality after bariatric surgery group, the projected mortality even after 30 years, 35 and 40 years was significantly higher. So people live longer in this prospective observational study. People live longer if they have obesity and they were treated with bariatric surgery versus diet and exercise alone. And this is another study looking at the cumulative mortality, again, in the metabolic surgery arms versus the non-surgical controls. And at the authors concluded here that the median life expectancy was 9.3 years longer if you had diabetes and you actually had bariatric surgery to treat your diabetes versus the non-surgical group. Some other additional benefits of metabolic surgery are, we know that it's a powerful intervention for people who have sleep apnea, quality of life. There are many, many studies on quality of life, also metabolic liver disease and even nephropathy. So all towards benefits in people who've had a metabolic surgery versus just diet and exercise alone. So again, when Siddhartha is asking, okay, so this looks all great. It looks like my diabetes will probably improve, cardiovascular risk will improve, but is it safe? Like, why isn't this being done more often or offered more often? There must be some safety risk. So this is a question for you. I don't have any polls, but just think about it think about it on your own here. What percentage of eligible patients, at least in the United States, who actually are eligible for bariatric surgery but actually have it? So only 0.5%, 0.5% of people who have obesity and are eligible to have surgery as an intervention to treat their chronic disease actually receive bariatric surgery. So you can see it's a very, very low percentage, despite its safety. So this slide is looking at safety data, looking at what is the complication rate after Roux-en-Y gastric bypass or mortality after Roux-en-Y gastric bypass compared to some of the other commonly performed procedures like a colectomy or a hysterectomy or a CABG or coronary artery bypass graft, which none of us would deny to our patients. So you can see the complication rate of the bariatric surgeries here in the blue, and the mortality, this arrow is again on the mortality side is pointing to the Roux-en-Y gastric bypass. And you can see it is comparable to a hysterectomy and much, much safer. Complication rates are much, much lower than a CABG. And so this also is true for mortality after a bariatric surgery. And this was an old study. This was done in 2015, before laparoscopic bariatric surgery was more common. So then, again, this is a rhetorical question, but why isn't bariatric surgery performed more often? Think about your own practice, think about your colleagues, and why isn't it recommended? I wish in another format, we would probably discuss this in more detail, but this is just food for thought for you. Why isn't it performed more often for treatment of these metabolic disorders if all of the randomized controlled trials and observational data that we have up to 30 years now showing benefit, why isn't it performed more often? Well, I mean, like any intervention, it has complications, surgical complications. This is just a list of some of the things that can happen, like ulcers and small bowel obstruction, fistulas, infections, and so on and so forth. And these are surgical complications that can happen really with any gut surgery. But metabolic complications sometimes that we are afraid of as maybe diabetologists or endocrinologists or obesity specialists, we're worried about nutritional deficiencies, electrolyte imbalances, dumping hypoglycemia, and so on and so forth. So those are some of the metabolic complications. But you can see they're not that different or more severe in particular than what we see from some of the medicines that we use for obesity management. And of course, weight regain. There is a subset of individuals who probably we don't understand their physiology well enough that they have resistant obesity. They're not losing weight as fast or as expected. And then the weight regain is another topic for discussion. But it just shows you that obesity is a chronic disease, and there will be periods of relapse again. So in conclusion, metabolic surgery is the most effective treatment we have for obesity at this time. It's also a very effective treatment for type 2 diabetes, and it's safe in high volume centers with surgeons who perform many of these per year. But it continues to be an underutilized intervention, and we should think about it with newer therapies to maximize benefits. And to answer the question, is it moving the tide? I think there are some lingering questions that we must answer ourselves as non-surgeons before we can say whether or not the tide is shifting. How does metabolic surgery compare to newer medications like the GLP-1 receptor agonist that we have? And is there an added benefit if we use these newer medications that have cardiovascular benefits? Are there added benefits to metabolic surgery? Can we even maximize both benefits together? Is it time to reform guidelines as well? Should we be recommending weight loss surgery based on the duration of diabetes or body mass index or the severity of insulin resistance, rather than just looking at a BMI as our criteria for recommendation? And then how can we maximize access to intervention? How can we work better and more efficiently in a multidisciplinary team altogether so that the appropriate patient is chosen for this intervention and followed for outcomes? And with that, I will conclude, and I hope I'm not over time. So thank you very much.
Thank you, Dr. Hafida, for the wonderful presentation.